In this period, we have achieved, also in our country, also in Italy, reimbursement and registration of a double opportunity bispecific antibodies based. We have available both teclistamab and elranatamab. They are both anti-CD3, anti-BCMA, bispecific antibodies. We know the data are particularly brilliant from the clinical trials, the registrative trials, and I think that we have incredible opportunity to use them in a not selected population, because till now we had to use them in clinical trials, not only monotherapy, also in combinations. Why bispecific antibodies? Because I think that in patients who relapse after monoclonal antibody or lose the response to a monoclonal antibody based on the regimen, bispecific antibodies the best that we can use in terms of fast response, deep response, because we know that these drugs are able to achieve the deepest responses possible in every treated patients. The only dark point is about the infections, and we know that it's really important the prophylaxis of our patients, also in terms of replacement of immunoglobulin according to the protection of the patients to infection, particularly pulmonary ones. But I think that in terms of effectiveness and of tolerability, apart from the needed prophylaxis, these are the best that we can offer to our patients. And in particular, in terms of sequencing, I think that we have to use as soon as possible after the failure of daratumumab or rituximab-based regimens, and we have particularly to explore the new opportunities also with these drugs. And we know that Majestic 3 and Magnetism 5 will answer the response about the possibility to combine bispecific and monoclonal antibodies. And I strongly think that if we balance with the good dosage and with the good ancillary treatments in terms of prophylaxis, this can be a new potential standard of care, also challenging the monoclonal antibodies previously used. And I think that another really important point is to study MRD status also in our clinical practice, because I think that considering the quality of these opportunities, we can be really ambitious also in every treated patients, because if they respond, we want to understand how much they respond. And I hope that we will also be able to explore new biomarkers in order to optimize these treatments, optimize in terms of sequencing, but also in terms of in some way reducing and balancing the dosage according to the obtaining of the best responses possible. I imagine in next future that we will have an MRD-driven approach in which we will maybe balance the dose according to a sustained MRD negativity. And I strongly hope that we will be able also to obtain a treatment-free remission like we have today in chronic myeloid leukemia. I think that myeloma today is a chronic disease, so we have in some way to understand when is the moment of performing a washout for our patients, because they don't want to be treated every day for all their life. So I think that these are other ambitious objectives that we have to maintain for the next future. However, I think that all the drugs that we are aiming able to use are saying that we are treating myeloma and we are curing myeloma, and I hope that the cure is not so far. And I think that this is the best wish that we can give to our patients, to their caregivers, and to all myeloma researchers.